about health insurance and disparities. So what do you want to know about that? How can we promote Healthy Baby 2020? How are we improving and making our babies healthier? Okay? The entire regular checkups, what else? Like what? Like for the pregnant mothers, we have the WIG, right? And it continue to go on, right? We got Medicaid, things like that can help. We got the all kids. If mom does not make as much monies or whatever, the children will qualify for that, so they'll have great health insurance just like everyone else. Things like that. We're immunizing our children. We encourage our infant from infancy on up to be immunized, right? So that's helping with health promotion and preventing different disease processes from occurring. We want everyone to be insured, and so by some of those things that we described, they can be. Just because, maybe mom doesn't work or whatever the case may be, due to poverty or whatever the case may be, it doesn't mean that our kids won't be taken care of and insured. A lot of our border health clinics throughout the counties, we can take our children there to see physicians, to get well baby checkups, sick baby checkups, to be immunized. And if we don't have monies, everything is free. So that's important there. What are some disparities?
Minorities.
Tell me about that part.
Low income families.
Lack of knowledge. Lack of resources. In our rural areas, right? So we're trying to make sure that we still have either physicians available there, clinics set up, or nurse practitioners. Our nurse practitioners are really helping us a whole lot, increase it in improving healthcare and making it more visible where physicians are there. And they're doing a lot of teaching. We have a lot of home health visits being made and things like that. So we try to educate as much as we possibly can in every way that we can. So tell us about nutrition and obesity. So important for our children to be to receive the proper nutrition, and that begins in utero, right? And then it continues on in the extrauterine life. And so we're making sure we say breast is best, and then we still recommend, if they don't want to do that, using a formula, but making sure mom is educated on and knows how to mix the formula properly so children can receive the nutrients that they should. And then we're making sure that we introduce things to the baby appropriately, like the fruits and vegetables, around about age 4 months, rice cereal prior to that. We would like for them to feed them rice cereal on the spoon instead of putting it in the bottle, right? And piercing holes in the nipples and making it very, very large, and then sometimes they choke on it, aspirate, things like that. So we don't want solid foods. Some do, and we see those babies really have more allergies as they grow up if you kind of give them solid foods too quickly and things like that. So they should have their fruits and vegetables and all of that up until age 1. The baby foods, right? We should have formula up until age 1, 12 months of age. When does the infant's weight? Tell me something about the weight at birth. What's the average weight for a baby being born at birth? How many pounds? Okay. About the average weight, 5 to 8. And so, what happens at 12 months of age? Triples. So if they're born with 5 pounds at birth, then at 1 year, what? 15. Okay. So you should see that question again, right? Birth weight triples at 12 months. That's even an NCLEX question, really, sometimes. Triples by the end of the first year. 6 to 12 months, they may gain about 3 to 5 ounces in weight gain there. The birth length pretty much doubles by the age of 4, preschooler's age. And then it might triple around about school age, children's age. Or triples by about 13 years of age, sorry.
It doubles. Can you repeat that?
The birth length doubles by the age 4, may triple by the age 13. We may double the child's height at 2 years of age to kind of like estimate how tall he or she may be as an adult. That's just something, that's just FYI, that's not nothing you really gotta know. Just thought I would say that. What do we know about childhood obesity? What's happening and why is childhood obesity so prevalent? Lack of activity. They're sitting at the computers, playing the hand games. What did you say?
Fortnite, a video game. That's like
Game, Fortnite. Okay. And so we're allowing them to do that at home. And then what about the eateries that they go to? Fast food, right? And so just increasing calories. That's not good though, right? The epidemic has really gotten bad, right? We have our 12, 13-year-old children diagnosed with diabetes because we know about the complications from diabetes. And what are some of those?
Complications. Keloid pancreas and heart problems.
But what are the major complications they have? Nephropathies, right? Neuropathies. And so just think, if you are diagnosed with type 2 diabetes at age 12 or 13, you may or may not be on insulin, or you could be on, oral medication, but just, the longevity, probably, you may make it to 30 or 40 years of age if you live that long based on how well you're taking care of yourself. So we're increasing in the schools, we're removing snacks out of the vending machines, making things more healthier and making more healthy menus, for the children to choose from, but we can't control everything at home. One pediatrician said last spring at a conference that he was wondering why the child would do well, seemed like when he was with the parents and things like that, they were getting the weight under control, but then seemed like the mom said she's not sure because Monday through Friday he's with them. But on the weekend, the grandparents got him. Mm-hmm. So that's where the problem was, So they had to bring grandparents in who loved, the young man, the little boy so much, but was feeding him, letting him eat everything. And your parents are not they're starving you at home, and And so the parents thinking that they're taking care of everything, and they really weren't. So we just got to work on that. That's big. That's a big problem there. All right. Mental health problems. What's one of our number one problems that we're dealing with our adolescents, I guess? And then I guess we do have ADHD being big, for our elementary kids and things like that. Just got to be careful with, let me just say this so I say it right. With who's diagnosing, because teachers don't have the knowledge to diagnose a child with ADHD. They can identify some symptoms and things like that, but ultimately the responsibility is a clinical psychologist. So just be mindful of that. My concern is sometimes the teacher who feels as though Susie won't be still. Susie's 5 years old. Really? Yeah. Susie won't sit still. She's getting up interrupted. Really? Yeah. So you got to be mindful, and as parents, you got to go and communicate, And so then they're filling out the paperwork and saying, now I feel as though she needs to be seen by her physician and be, on medication. Medication is very, very strong, right? Very sedating. The kids are kind of like what? Just zombies. Really? Yeah, and so just be mindful of that, that it's when the final diagnosis is made, clinical psychologist does that. And so for our adolescents, what problems are we dealing with? Suicide and bullying, and what else?
Smart mouth.
Depression.
Adolescent and college students, what we dealing with? Depression, and what else? What else?
Sexual activity.
What else? Anxiety. Don't we see that? Everybody's on some type of anti-anxiety medication. And they're saying that they're having problems coping. You need to come in. What's the...
Sorry, Bob.
That's
I'm
okay.
missing a computer.
Are you? What number?
Number 8, somebody who's upstairs. Did somebody take a test in this classroom upstairs?
A bunch of us did, so it may be, but they all show apart.
I got 9 out of the 8.
You got
Now,
9
we
out
had
of 8. That's
down
an extra
here.
one.
8 out of the 9.
Oh.
Yeah, I got 8 computers out of 9.
I was like, you need to put one
So
back.
you said you missing
I'm
the
missing
ninth
number
computer.
8. Right. I'm missing computer number 8 out of cart 2.
Did you check the area?
Yes, I've already been up there, checked all the rooms.
And so,
Who was the last one up there?
It was on the cart.
What number did you have?
No idea. The lady saw me. She said it was on the
Yeah,
cart.
that's what I'm saying. I got them all down that was up there on the cart, and I'm still missing one. So
Was there not? No, I don't think so. I don't think so.
what 2 carts do we have here?
y'all's is
7
in
and 8.
Oh,
there.
so we're good there.
Right. I went to the classroom down there,
Uh-huh.
and they said they turned all theirs in, and then there was one left here.
So the
So I
ones
just
up
checked.
there, what
That's
cart?
the one
do
I'm
they-
missing.
What cart do they go
Cart
to?
number 2.
And where's that? In the
It's
other
in room
classroom?
128 now, but it was in room 131.
Okay, so
So-
130. Well,
Yeah.
131 students who needed to take test upstairs would, yeah.
I've already checked with them.
Yeah, uh-huh.
All
So,
right.
yeah, I think that's where, yeah.
No, they don't have it.
They don't
said
have
you got here.
Yeah, we wouldn't
we only
have
have 4
those,
people.
I don't think. Right, because they, you know.
Well, 7 and 8 is fine. We have cars 7 and 8.
Yeah.
We're in the clear.
We're good. They don't take time.
Sorry. Thank you.
Yeah, we did have one and check upstairs and ask Miss Elaine and Miss Holt. Miss Holt had her own, but it was one that was, I don't know.
Miss Coleman had a student.
Yeah, that's what I'm saying. But that's what I was trying to see. Did she take a computer with her up there?
She put it back.
Oh, no, on the podium.
Oh, no.
Okay. I can't see that
I
far.
was like, where? Okay, so back to this little quick lecture. It didn't take it too long. 5 questions, right? So everybody understand what's going on there. A lot of things are going on, coping. I don't know. We have a lot of drug use, right, going on too with that age group. And I don't know. How do we make that problem better? How do we help with anxiety and the coping? What are they coping with? I don't really get it. Now, I've dealt with students, even in college, college students, they said anxiety is pretty bad.
Yeah.
But I'm not quite sure why anxiety is so terrible for you all. You have a long ways to go.
I am like,
I mean, I'm not sure why anxiety is a big problem for this age group, because you got a long ways to go if you're not able to cope well.
sometimes people are not taught the proper techniques to deal with anxiety, and
Like,
it's coping. It is coping, but at the same time, I mean, it's a very real situation. Like, I don't want to look at Tristan and be like, oh, you got anxiety, girl. No, you don't. You fine. Look at you. You just great. Amazing.
so how do we cope with anxiety? What's a good way to cope with anxiety?
Well, like my test anxiety, they just say that breathing techniques,
Deep breathing. Yeah.
focus is a big deal, and sleep. Yeah. Eat right. Well, I didn't try that one yet. I'm gonna get to it. Exercise doesn't help. Okay, good. I'm gonna skip.
So exercise, trying to eat healthier, and I think too, in growing up, no one really. I think test taking strategies should be implemented at a very young age. So, you know, like elementary or something like that. So
But they're
I think
not.
that's a big thing because I can, you know, attest to that. You know, I don't know. Yeah. Yeah. Just
Like the
always
tactile
anxious.
learners or
Yeah.
the visual, like I didn't learn any of that until I got to college. I really could have used that
Right.
in high school
Right,
or even
yeah, that's what I'm
elementary
saying. You
school.
could have just improved. You can see how you could improve because really, if your anxiety level is up, you're probably messing on about at least what 5 or more test questions. So there's at least 10-point, something or more. You know, because you can't really just think, you know, clearly because you still, you know, So so just exercise, get good night's rest, things like that should help. We should not need any substances to help us cope. And that's not good because it's just not, because you can become addicted, you know, to things. And so that's what the problem has happened.
Well,
You know,
and, well, a lot of
kids
folks
are taking
too are,
medications
they have a
from parents,
chemical
grandparents,
imbalance.
things like that.
So they will need.
So what'd you say now?
You know, some folks to have a chemical imbalance within them, a brain that has been tested.
Yeah,
and
once
can be.
that's been detected. Now,
Yeah,
everybody don't
yeah.
have no chemical imbalance.
No. Some of these folks walking around, they're just not
Increase
right.
in dopamine and all of that, you know, that kind of does lead to a person, you know, having schizophrenia.
Yeah.
You know, and then, you know, the serotonin and things like that can be, you know, due to being, you know, make, you know, cause of, as you're saying, very depressive, but everybody don't really, we just got to learn how to cope.
Yeah.
Then some things are just so overwhelming that we, when we, that we can't cope, you know.
Yeah.
Alrighty.
Can you put the thing down?
Just green.
Oh, I'm sorry. Oh, why you didn't tell me? Just don't have time for lecture. That's really funny, but it's not.
I mean, I did, but I didn't want to bother you. I didn't want to stop her from listening.
I didn't even pay any attention. I'm just looking at the clock. Okay.
Oh, the 10
So
thing.
cephalocaudal, proximal distal, differentiation, sequential, developmental pace, sensitive periods, objective two, your principles of growth and development. So that's kind of like how the newborn baby, right? The development is. And so tell me about cephalocaudal.
Oh, that's I think.
Head to tail, right? It's the head to tail. The most evident in total body growth is indicated by changes. During your fetal development, the head is the fastest growing body part. And at 2 months of gestation, the head constitutes about 50% of the total body length. So during infancy, the growth of the trunk predominates. The legs are the most rapidly growing past during childhood, and in adolescent, the trunk again elongates. In newborn infants, the lower limbs are pretty much the 1/3 the total body length, but only 15% of the total body weight. The head comprises most of it, right? So you see the little toddler kind of like wobbling, right? In their gait, but the head is the largest part. So we say head to tail, which is the lower extremities, right? So the proximal distal. Can somebody give me an example? Tell me about that. Anyone? Not everybody at the same time.
Is everything you just said for that important? And if so, can you go down to it?
The cephalocaudal. Just saying that that's the position of the head to tail, right? And it just identifies that the head constitutes about 50% of the total body length. We're just kind of like stating that the head is the largest part of the, infant's body, as opposed to the trunk. And then as they begin to walk and ambulate and things like that, you see the unsteady gait, maybe the bow legs to the lower extremity and things like that. Not just that they just kind of like want you to be able to understand just a little bit. Okay, proximal distal, what is that pretty much identifying?
Coming from the arms and legs and going inner.
Coming from what now?
The arms and legs going inner towards the shoulders.
Like adducting.
It's like how they move their trunk for their arms. Like they can roll, but they can't move their arms.
Right, and the ability to crawl and things like that.
I don't understand
Say that again now. The proximal distal is just stating how the trunk, there you'll see movement of the trunk before you see the extremities. And so even with crawling, right, don't you see the trunk trying to move more so than the infant having until they can really begin to crawl effectively as they get older? Yeah, that's just the proximal distal. It's not nothing that you just really, we just want you to be aware of, but, okay. So differentiation, what is that? Don't let the same people say the same, speak. What's differentiation? Say that again. So what are some of the gross motor skills?
Holding before letting go.
Holding. What about pentagraph? No? Is that fine? Okay. And what's the gross? Holding what?
Bottle.
Cup. Things like that. Okay. Sequential. Everything is in sequence.
Crawl,
As it should
walk,
happen.
run.
Okay. They cannot start walking until they start crawling, right? They start crawling, then they begin to start pulling up a little bit, right? Then they start pulling up, and they may even hold on to an object, right? And then you kind of see them make a few steps, and yeah, they are fearful, because they don't want to fall and hurt themselves, and so need a little bit of assistance. Developmental pace, growth and development, everything what is paced as they milestones by age. Some children begin walking at 7 or 8 months old. But it doesn't mean that everyone, right? And there's nothing wrong with your child. But the child that's not sitting up properly without assistance by what age? About 7 months old. And really don't say 8, then something is going on there, right? And so we need to assess it. The child that's still babbling by what age? About 6 months, 3 to 6 months or something like that. And then we're what? Assessing for what? Autism, and and then so you may see it continue. Very, very hurtful for the parents, because it really does. It's not detected in utero. I mean, it cannot. I don't think. Well, I guess maybe there may be some extensive tests that can be done, but it's very, the child looks normal. Normal development systems are good and things like that. But then you kind of notice something. So to me, a lot of them they stare a lot more to the baby that may have the autism and things like that. But you'll see the 3-year-old, just babbling, even though they look healthy, they're growing, height, weight, everything's appropriate and things like that. But then you'll hear them say something, and then they may repeat it, and things like that.
Isn't it like, don't they say like once?
One.
Syllable.
Yeah. Say that again.
Isn't that a sign, the bad sign for one syllable or whatever?
Say it again.
One word
say
sentence.
one syllable, repeating. And that's pretty much what they do. They repeat, and then they repeat what they hear you say, and then they'll keep saying it, and then they'll keep saying it, And so it's quite, it's a lot of work, So, I mean, there are different types of autism, and so some, can function, some are learning. And some autistic kids are really, really very bright, So it just depends, and it depends on what kind of care and if we can get an early diagnosis and then get some treatment for them, so things like that. So what are some of the sensitive periods? Can you speak louder?
Early bonding.
Early bonding. What else? What's so important about bonding?
It shows care.
Maybe you can get trust.
When do we see the trust versus mistrust?
Oh, that's the 81. What's that?
Infant, 0 to 18 months.
0 to 18 months. What about strange anxiety? What's so important about that?
Because they're not used to that person.
When do we see that?
Like 2.
Anywhere from what? Infancy until about 2. Or it can be a little bit longer, right? And so what does the child do? They cling to them. They're almost about to climb over the parent's back, right? Trying to get away from you. Some children just really don't like strangers, even if it's their, grandparents or what, some it take a while to adjust and know. They just trust their parents, right? Yeah. And so, so that's important for us to try to be great parents, there. So therapeutic relationships, define a therapeutic relationship.
Effective, professional, not personal.
Essential
And
foundation for
what are we trying to do there? How can I have a therapeutic relationship with the mother and father?
Give them good care.
Trust, explaining, eye contact, things like that. Family advocacy and caring. Who are the advocates for our children?
The parents.
Parents, nurses, doctors, social workers, Department of Human Resource, police officers, everybody, right? Whenever we see something, I know you guys heard that talk at the M&A thing. Whenever you see something, you're supposed to report it and document, right? A lot of people don't believe that, but that's very, very important. And so you can't be held liable, right? You can't be fined, and you can't even do some time in prison for not, identifying, preventing things happening to our children. So disease prevention is how? It's done how?
Education.
Immunizations is number one. Dental care, hand hygiene, education, proper nutrition. Explaining the importance, the scheduling of, well baby visits that mom should make, when your child should be, an infant should be immunized, and all of those. Promoting a healthy baby, from diet, to nutrition, to immunizations, to preventing injury, to car seat safety, to no toys in the crib, preventing SIDS, all of that's health promotion and disease prevention and all of that. Making sure they get the well baby visit checkups, because then things are identified, right? The doctor can assess them. He can find out, I didn't know that was going on. I mean, your baby hadn't seen a doctor in over a year, and maybe sometimes the parents are taking care of those things at home. So we want to make sure that we address all of that. Support and counseling, who is that done by? Support and counseling. Who does that? The nurse can, physician can bring the social worker in, can make some referrals, right? Yes, the school teacher may need to make a referral for the child to be seen by the pediatrician. She may have a complete document record that she's been monitoring the child for 1 full month or a couple of months, and these things have been going on, and so now we make other referrals there, and we may or may not. But I don't think it's always the best thing to do is to medicate first. I think we need to evaluate, just make sure that we're evaluating carefully, and make sure that we can identify everything in the manner that it should be. How do we coordinate care, and who do we collaborate with? How do we coordinate care, and who do we collaborate with?
Doctors.
With other healthcare providers.
Healthcare, school teachers, school nurse, school teachers, physician. Even though the pediatric child is coming in for tonsillectomy, we still may have to do a round table. And what people can we possibly have there? What people can we possibly have there for the child who has really been abused? What people are at the table? Social worker, therapist, maybe somebody from the Department of Human Resources, physician, nurse, could be occupational therapist, physical therapist, respiratory therapist, whatever it takes to take care of that baby and to get them, the help that they need and things like that. We may even have, since they are going home with the grandparents, we have the grandparents present. So the more more individuals we have to be concerned about the care of the child, the better. It's a better plan of caring for them, because everybody's going to give their opinion and tell you what things are going on. When I'm entering the room and assessing and things like that, the physician is going to tell you about the past medical history, maybe even of the parents of the child and things like that. And so we're going to get everything done. What is ethical decision making? What makes it ethical? Right or wrong, and it's based on what? Based on what? Morals, values, the law, right? all of that, ethical decision making. Is this the right thing to do? Does that fall within my scope of practice? You know, am I doing what I should as a prudent nurse? Research is very, very important because it can identify. We can, I'm sure they're spending a lot of dollars now, research on infant mortality and maternal mortality, morbidity, type 2 childhood diabetes. We're just trying to see how can we make it better, what can we do. So research kind of like enhances, makes it better. We're trying to find a cure for all of our cancers and things like that. We always want to have family-centered care. When we talk about family-centered care, what are we talking about?
Everybody that can.
Does it include the brothers, sisters?
Yeah.
When little Susie's admitted to the hospital, it does, right? It includes everyone who's caring for the child. Includes the play therapist, you know, from the tree house, where the little toddler can go and visit and play and, you know, make it seem more like home. The parents, the doctors, the nurses, and things like that. And anyone that will be caring for the child, maybe even someone from daycare, you know, might need to come and listen to the plan and maybe even identify, you know, possibly something that happened there. So, what's important about the psychosocial history? What comprises the psychosocial history?
How they are, like how they
Interact.
Yeah.
Interact with their peers, adolescent-wise, school age, toddler, preschoolers, and all of that. Kind of like talked about some of the sensory motor development already, intellectual development. How do we assess and evaluate our children based on what? Milestones that they should reach, right? Things that they should be doing at the different ages, physically, right? Sociably, psychosocially, when they should be speaking 1 to 2 sentences, when they should be crawling, when they should be walking, and all of that. I'm not gonna say much about that one. Rest is best. Not gonna say much there. I think we talked about that. They are saying the healthy plate now. So the healthy plate shows that my foods should look like what? Very, very colorful. So fruits and vegetables mostly, right? Small amount of protein, and that comprises few carbs, right? Comprises a very healthy plate for our children. And we've already said when do we introduce solids?
4 to 6
foods.
months.
4 to 6. No. Solid?
4
foods.
4 to 6 months.
Solid foods.
Solid. About a
Mashed
year.
potatoes, grits.
12.
Yeah, okay. About a year. Fruits
Rice
and
and
vegetables
cereal.
and things like that for.
Rice and cereal is 4 to 6 months.
Yeah, they can get juice. Yeah, they can get the fruit juices at 6 months. But
Oh, these notes are wrong.
solid foods, yeah. So when do we wean? Mom said that the baby is begin drinking out of the sippy cup because she can hold it by 7 months of age, and that's all she wants to do is use this. She doesn't want the bottle anymore. So I've just been giving her juice, you know, and water. Is that good? What? And what else?
She's not getting enough
Bone
nutrients.
development, calcium. So what do we tell her about weaning? The child really does. The infant does wean themselves, right?
Yeah.
A lot of them do. Some maybe about 10 months, they don't really want that bottle as much. So what can we do? What do we do with the formula? What do we do with the breast milk?
Start putting in sippy cup.
Put it in a sippy cup.
Right.
So we got to give it to them, right? They need it, right? So we have to educate.
When do you wean it?
You can begin weaning, and children really wean on themselves, but pretty much you are totally weaned by almost a year of age. But you should not take them off of their breast milk and or formula. They can be off of the breast and they can be off of the bottle, but they still should be drinking less than 1 year. Okay, some are drinking, and breastfeeding, 2, 3. I mean, I know one maybe about 4 to 5, but she had Downs. So some other things going on. She not only have Downs, but she had leukemia, and so you know you can understand that.
Wow.
So, but the breast is best. A lot of parents are breastfeeding up until about 2 years of age. Really and truly, they're very, very healthy babies. Very, very healthy babies. And even to me, you don't even see them, you know, getting sick easily. You know, they're just very healthy babies. And probably the mom is breastfeeding that long and then she's really, really healthy, you know. She may be doing everything organic and giving them fruits and vegetables and things like that. All right, safety issues, aspiration of foreign objects. Is that a big problem?
Yeah.
Like, why?
Because they like to stick everything in the mouth.
Put everything, the toddler, well, we see that in the what? You know, toddler, they begin walking 1 year, 2 years of age. They touch everything. So we got to make that home safe, right? I think we've covered that, covering the, what?
The outlets.
No frayed wires and plugs, security gate, all of that. Medicine, they try to make sure the tops are really, but caustic agents, you know, cleaning, all that should not really be in the lower cabinets, right? Because they can get to them. What do we do for our poisons? You know, Mom said that he drank the Clorox. What do we do? Do I go head on and take care of that and rinse his mouth out or give him milk to drink? What do I do? What's the first thing?
Call poison control.
Always. Should have the poison control number where?
On the fridge.
Very, very close by. Very, very close by. Motor vehicle injuries, we're seeing that with our adolescents. We need to educate our children on what? Wear our helmets, elbow pads, knee pads. When they begin riding bikes and things like that, all that is great. You know, it's fun to see dad and the son with the go-kart, but where's the helmet? Really? Yes. Can't get a new brain, right? Can't get a new brain. You know, so when I mean, really. So that's my only thing. Head injury, right? Yeah. Head injury, yeah. No head injury. I don't want that. You know, the kid wants to roller skate outside and do all this, but they got to wear that helmet. You know, so we got to encourage that. Frequent falls, we see that with our toddlers, right? Burns, mom needs a security gate, you know, probably to the kitchen, right? She don't need to be allowing the 2-year-old, even the baby that's crawling, they'll do that, right? Won't they crawl? They crawl and follow you wherever, yeah. And so you're cooking and things like that, yeah. We need to teach our children once they can understand and things like that, that this is hot, this no, and things like that, so they won't enter and, you know, yeah. We want to prevent that as much as possible. So prevention. Suffocation, how can they suffocate? Face down,
Pillows.
prone position, pillow,
Sleeping in the bed with you.
sleeping in the bed with, yeah. Some parents have rolled over, right? So they should not, that's why it's not good to start them from infancy, right, sleeping with you. But I think we all can say, yeah, we're guilty of that. I mean, I am, yeah. Thank God, nothing, you know, majorly happened.
Sure ain't.
Drownings, you know. We need the gate around the pool. We just see that so much that the toddlers, always maybe like the 2 to 4 year of age, you know. They thought they were in the house and they walked out the gate. The gate was unlocked, and then nobody knows, and that's the main thing. The submersion underwater, we don't know how long they were, and so prognosis very poor. I mean, I haven't seen many cases yet, very poor, and so that's very, very, you know, the parents are distraught, you know. All right. How do we respect our cultural differences? Do we know what the family who's Japanese things, what are some of their cultural beliefs, and Chinese, and what are their beliefs about this, and hot tea methods, and should they, you know, are they introducing that to the child? Am I saying that you can't have that? But I got to understand the culture, right?
Yeah.
You something that's supposed to look like child abuse, but it's not.
It's coining.
What's
Called
coining?
They take a coin and scrape the body, and it'll make a bruise and marks and
so somebody could think possible abuse.
yep.
So just make sure you
Down the
guys
chest,
review
up
over
the
your
back.
cultural differences and things there.
Yeah, look it up. It's called coining.
Someone who's Jehovah's Witness, you know, the child needs the blood. The parents said no.
Yeah.
So what are we going by?
Their
We do
culture.
respect their beliefs, right?
Yes.
We do respect their beliefs. I have seen a few occasions where the physician said, no, this has to be done. You know, a few occasions, but not many. Be mindful of the Muslims, and I hope I'm not saying anything, I'm not trying to say anything to anyone about anything wrong. So be mindful of everyone and what they don't eat pork.
No.
So don't bring them any ham, you know? Please don't let that be on their tray. They will really, yeah. You remember it if you do it just one time. Yeah. I promise you. I've had the experience, you know. Just sorry, but you know they don't want to hear that. You really don't. They don't want you anymore. The nerves know. That you shouldn't be ignorant to the cultures, right?
Yeah.
You should not be ignorant. You should be very knowledgeable. If you got to sit and Google something, if you got to ask some questions, if you need to even ask the parents, you know, well, what, and so you got to know that. Okay?
We don't have the right to do that, do we? If they deny the blood for the baby?
Oh no, we don't have not that. I'm
Oh.
saying if you don't understand about their cultural beliefs, and you need to know it. You need to be knowledgeable.
Yeah.
So you don't need to be saying I made that mistake because I did not know. That's unexcusable.
Yeah.
Right.
And if they deny the blood for the baby, they have say so.
Yeah.
So we got to communicate. All right. What are our methods of communicating? What are our methods of communicating for the infant?
Crying.
What do they do? When they're crying, then can I distinguish between that cry and tell if they're probably hungry, if they're wet, if they're what? Okay. Early childhood. Does no for the toddler, what does that mean? No can mean yes, no can mean anything, right? But they say no to everything, right?
I thought it meant yes.
The preschooler, the 4 or 5-year-old, they can communicate pretty well to you, right? They should be, unless there's some delay, developmental delay there. School age, they ask a lot of questions, right? You have to demonstrate. The toddler, well, they imitate things, right? The school age, they're magical, and so they like to dress up and they like to do things like that. They like to bring dolls in to demonstrate. The adolescent, trust is very important. You have to tell them exactly what it is and whatever you're going to be doing. They don't want you to ever lie to them and not tell them, the truth, because they really probably don't want you as a nurse anymore. Promise you so. They love their peers, right?
Mm-hmm. Their friends.
We've already talked about diet, sleep, the well child and preventative care. I think we've covered that. I think we've gone over medications that you all should understand. Oral, how do we say you administer oral medication?
Back
Back of the sheet. The oral mucosa, try to hold them. You know how to give an IM injection, always the vastus lateralis, maybe up until about 2 or 3. Everybody know how to do subcutaneous, intradermal. IV, we may have to do a therapeutic restraint, right? Mm-hmm. We may have to put them in a papoose board, things like that. Pain. How do I assess pain in the infant?
Every 30 minutes for IV, 1 hour for
Their
oral.
facial expressions.
They're crying, right? I sure cry. Maybe be kicking a little bit, showing things like
grimacing.
that. What about the faces?
Yeah.
Maybe grimacing.
Can I use the different faces that can
Yes.
show me maybe in the toddler? They're beginning to cry. You'll see them pucker their lips and things like that. And we can probably use that a little bit in the older preschooler and things like that. We compare that face to that. Non-pharmacological is best, right?
Yeah.
We can do the holding. We can comfort them that way. Wrap them up in the blanket, things like that. What can we do for the toddler? Non-pharmacological.
Yeah,
Toys, play with them,
Ice cream.
have fun.
Yeah.
School age, maybe let them color, let them play, dress up as much as possible. You can dress up if they're really that ill. The leukemic patient, make them laugh, have fun with them, right? Yeah. Pharmacologic, always give it very, very slow.
Act like Patch Adams.
They just really, really have a
Put a clown nose on.
they don't tolerate any intravenous medications well. I've given Finnegan maybe to a 6 or 7-year-old. It just wasn't great. I didn't like the way she slept for a while, long time. I've given morphine to a baby infant who had a hernia repair. Yeah, called throughout the night. He slept throughout the night. The next morning, really? I got that discontinued the next morning. Yeah, we don't need that. Safe dosage, we gave it, but I just didn't like that. So I don't like to give anything intravenously. I'm very, very cautious. I don't care who it is, child, adult, or whatever. It goes to the systemic quickly.
Yes.
It really does. You know, you can cause some major problems giving medication too fast. So always slow, cautious, know your time frame, the number of minutes. I try to dilute as much as I can. Some you cannot because it loses the potency and things like that. But just be careful. Everybody want to do things so quickly, intravenously. Yeah, you can cause some major problems with somebody intravenously. Do I need to say anything about the types of families? Everybody understand what the types of families you guys should?
What type of family?
The blended families, the nuclear family. Everybody understand the definition of those. We're going to keep moving on. Y'all should. Family types, purposes, implications in caring for children. We already kind of like we're overlapping. Safe environment. You know, nurturing is very, very important. We nurture them nutritionally. Just meeting that's anyone but our infants just holistically. If you take care of the client in a holistic manner, you can never go wrong, right? You can never go wrong. I've covered everything for them. I understand that mom is not working, dad is not working, you know, and so I know that they need to see the social worker. So I call the social worker. You know, I don't really have to talk to the doctor right then. Social worker talk to him. She'll make sure the order gets in, but we can start things and keep them going. Everybody understand that? So just taking care of them holistically. Right. So how do we identify strengths and how do we facilitate growth in the child? Just strengths in caring for the child, making sure that they're properly cared for, making sure mom is adequately taking care of the child, making sure the child is growing properly.
Yeah.
We know that they need their nutrition, their food. The home has to be safe. The parents have to be there. No abuse can be going on. All of that is going to facilitate and cause problems. Sorry, we're behind. We talked about separation anxiety. What do we talk about when we say loss of control? What does that has to do with?
That's their outburst.
That's school age kids having a temper tantrum.
Temper tantrums, loss of control. Want to do what they want to do. Don't want you to tell them no, right? Altered family roles. Sometimes dad is at home, right, taking care of the children, and mom is working. We can't give our opinion about that because it happens a lot, right? What do we know about our siblings when the children are being hospitalized? Be mindful of that. Be empathetic. Be cognizant of the parent, you know, who is just found out that the 3-year-old has leukemia, and both parents are working parents, you know, and so that's very traumatic for them. And so we need to just make sure that we can help as much as we possibly can, that we can try to help financially if we can. There are resources throughout the hospital and things like that. Sometimes the parents will make the room just really, really comfortable for the child. It resembles the room at home. We got to talk to the siblings. We got to include them in the care, you know, because that's where the sibling rivalry comes. The 5-year-old brother does not understand that his 3-year-old sister has leukemia, and that every time someone comes, that they bring her a gift, right? Yeah. So now we got to educate mom, and I do that. Educate mom and dad, even though I know that, you know, this is a new diagnosis. Everybody is upset, and they want to bring her, but we do educate mom to bring Johnny one as well. And then so we give Johnny things too. We take Johnny to the playroom, you know, maybe while the child is getting her chemotherapy and things like that. So be mindful of that. How do we prepare each and every child pre-procedurally? How do we prepare them?
Establish trust.
Say it again?
Establish trust.
Establish trust, but how can we prepare the 3-year-old for a procedure?
Allow them to explore.
The dog that has had the tonsillectomy, the dog that has the IV, the dog that has a cast on them, got to demonstrate, you know, things like that. We got to tell the adolescent the true story, what is really going to be happening, you know, possibly how you will be when you come back from the surgery and things like that, you know. Yes, we got to put this in your chest. It's going to be give you access to receive your medicine so you can get better because you have, you know, the child has been diagnosed with cancer, and so he's going to be given a strong medication. It could make you feel very sick, but we're going to give you some medicine to help you with that, with the nausea and vomiting and things like that. So according to age, we have to educate. Sometimes we bring them prior to the procedure, prior to the surgery, right, 3 or 4 days, take them through the hospital and things like that. All right. Planning for care for children during pre- and post-operative phases of surgery. We got to monitor everything. Pain management is very, very important. Just like I said, we set the room up for the for the laboring patient or the postpartum patient, we set the rooms up for our pediatric patients based on their diagnoses, right? They have seizures, a new baby coming in, 1-year-old coming in with seizure activity, then what? How do you set the room up? Suction. What else?
Bed rails padded.
Maybe oxygen,
Padded bed
maybe a
rails.
pulse oximeter, pad the rails, things like that. Can have most of the medications that are intravenous, anti-seizure medications at the bedside because they need to be refrigerated, but we are mindful of that. We do a height and weight chart, and if you turn it over, it have all the code medications that we can give and the dosage prescribed for that. Like on the front, I'll highlight the kilograms, 19 kilograms she weighs, and then I know it matches up with everything that child would need to receive. So we don't actually need to calculate. We should not. We feel as though that weight is accurate and things like that. So the RSV baby that's 3 months old, how do we set the room up? Respiratory syncytial virus.
The oxygen's gonna be in there for sure. Contact.
Contact isolation.
Yeah.
Pulse oximeter. Keep the head of the bed elevated. Make sit in their car seat, right?
Oxygen, suction.
Suction, oxygen. Yeah. Suction is the key with the respiratory syncytial virus. Nasopharyngeal suctioning. As long as you can suction every 2 hours, you'll see that child improve. If the respiratory rate is greater than 50 breaths per minute, then they're probably going to be nothing by mouth, and they'll be on intravenous fluids and things like that. So you got to know how. You got to know strict intake and output, we say, for pediatric patients, right? Meaning that we're weighing everything. And that's very, very important. Doctors are looking at that. That's how they continue to write orders. That's how they write their progress notes and things like that. So be mindful of that. Weight is very, very important. That's kilograms. Dosages are milligrams per kilograms. We want the safe, and we want the minimum, and we want the maximum. There's been several times that I found the dosage was too high. Very, very little where it was too low, but too high. Because we calculate, pharmacists sometimes misses it. So just be mindful of all of that. Positive reinforcement, even with the child who's diagnosed with with leukemia. I've seen many leukemic patients, survive and do well. So we want to give them as much positive, information as we possibly can. We want to tell them about the great physicians, the oncologists that we have here, and they've been here, and so we want to do all of that, to just kind of like make things better for the parents.
How do you do that without giving false studies?
Huh?
How do you do that without giving false studies?
We're just going to say what we kind of like possibly what I've experienced, and we can tell them about the disease, which they probably learn more about the disease, and just tell them some positive things, We're not going to say anything about yes, even though we know someone possibly have. I know somebody who's diagnosed with leukemia as a child, she lived to her early 30s. So I can give that example.
Yeah, I understand that, but sometimes they're going to be fine, but maybe they're not going to be fine.
That may be true. But that's not false hope, because I can't say that. I don't know if they're going to be fine. Leukemic patients really, really live a long period of time. But those who have the acute myelogenous leukemia, their survival is is lesser. But there could be an AML that's walking around still as an adult. So we just have to tell them that part. We're not really trying to give too much information, but we're just trying to make it as positive as we possibly can.
So what would be out of all of this, what would be something that we really need to go in? Is this 5 questions? But it's like a whole lot of
Everything that I said, no, I'm just kidding. I talked about pre and post procedure hospitalization. That's specific. I kind of said something that you all need to know, and so hopefully y'all remember that. It's a lot of information. It's basic, but I don't know if I can remember everything. But I'll give you some more next week. But that's basic 5 questions. Don't take that serious. I think you probably could answer those 5 questions without, just based on your human growth and development, that kind of thing. Okay? I think you'll be fine.
In the book, it says that you
Solid food.
Yeah.
What is it identifying solid food as?
The American Academy of Pediatrics recommends introducing solid foods after 6 months of age. Then it says it needs to be consumed and used from all food groups by 7 to 8 months of age.
Okay, well, that's something that's to change then, because
because we got the new book, so I don't know if y'all have access to the new
we
one
do,
yet.
but I'm just saying I still can't see you giving solid foods at 6
That's what we're
months.
testing on.
Yeah, I see that. Yeah. Okay.
I feel like that's what we need to be in the mindset of what we're going to test for.
Yeah, that's true. That's true. Okay, I'll look back at it. Because
I was looking
and
at
just But, you know, I didn't know if that was just their culture, so we didn't, you know, say, hey, I'm talking to the client. No, that's his wife. You know, so you got to use a little bit of common sense. Nursing is a lot of common sense.
So since it wasn't like causing them any harm, you were.
Well, not really, but I just still wanted to hear from her. We really wanted, the student and myself, we wanted to hear from her.
Yeah.
And she didn't look like a person that just could not communicate with you or had any type of, you know, mentally challenged or, you know, things like that. So that, to me, that was probably a part of their culture. You see what I'm saying? So, yeah, when the husband is, everything, you talk to him, even the physicians, you talk to him.
Yeah.
And so that's what I'm saying. So that's kind of like serious. You know, a nurse probably can get angry, you know, it just depends, but you shouldn't.
Yeah.
It's not a reason for me to get angry over that. I understand, and then I'm probably stepping over some boundaries.
As we go throughout the lecture today, we really
I can't hear you.
I can't hear myself neither.
What you say now? You picked up something, right? Viral, maybe?
I don't know. You want a hug?
My ass viral, maybe?
No. I think it's Larry does. Real quick, can you just kind of point out what we absolutely need to know? Why?
That's kind of like, that's not the
It's
right
very
thing to do.
conducive.
To point out, I've already gone over a couple of things just now, so I don't know if you guys got it yet. Basic concepts of pediatrics, I just went up to you. That was three test questions. That was three test questions.
Priority mean that it just has 5 questions on that?
Yeah.
Say that again.
What would be, like, what do we need to tunnel in on, being that it's so much information and you have 5 questions? What needs to be like our main focus on that topic?
You saying like per each system that we're talking about?
Yeah, like it's so much information.
It's not a lot. Go with your PowerPoints, go with the objectives, and then listen to the lecture.
No, I'm just talking about like guidance to like where we need it. I don't want to spend too much time on something that's not relevant to the test. That's what I'm talking about.
Oh, really?
Yeah, what she said.
You have to know it.
It's a lot.
You gotta know. I mean, the thing about it, you should know it, and you should not just be studying the material for the test, because that's going to come back and haunt you a little bit with future courses and things like that. When you take proctored tests and all that. So, I mean, I'm saying with the readings, the page numbers, and all of that, and we're telling you read only that. Look at the objectives. Look at the PowerPoint, and then that should clue you in. That's it. So don't read all of neurology or cognition chapters. You don't have to. If you have the time, that's great. But you should have already identified those areas that we're going to talk about today. So in cognition, what are we talking about today?
In cognition, it's Down syndrome and cerebral palsy.
Yeah, the cognition's tomorrow, I think.
Cognition's tomorrow, right?
Yeah, cognition tomorrow.
No, that's not today, that's tomorrow.
We start on pediatrics first.
Look at somebody's calendar real quick. Everybody got the calendar?
Go ahead. Go ahead. That's all just
Breathe, Justin.
Most of the people would have been last semester. I thought for us, we from that perspective, and so it's hard for us to hear that.
So with pediatric emergencies, what are we looking at today? Safety is the main thing there, right? And how to care for those clients
When you're looking for your
if one of those emergencies occur, right? This is the basic part of pediatric emergencies. It kind of overlaps a little bit of the basic concepts of pediatrics, but it's 5 questions again.
Well, probably most likely be on Johnson.
So you have 10 areas?
Mm-hmm.
10 areas, 5 questions. I don't think, I mean, if you study them by the systems, then you really should do fine. I mean, if you study it by each system, and it's just really not any way you can get the systems confused. I mean, it's not a way you can get that confused at all. I mean, I don't think. Do you?
Yeah.
You you can get the integument confused with what? And hydration.
No.
You can get those confused. Oxygenation. You can get those confused.
It has to go to them, though. All them have to find it.
You're good, Miss Hosey.
Like when Gary taught me, she gave us guidance.
I don't know, I think we just need
Everybody
to
teaches
start with
different,
something.
but I'm not supposed to pinpoint and say, oh, this is going to be on the test. This is going to be, because what I'm trying to do is lecture to you and be a little critical with it, and then let you think outside the box with it, and you gotta decipher, and you gotta be ready for the test. I can't just, I don't think I don't think you're learning if you're, I'm just telling you what's gonna be on the test.
She didn't tell us what was going to be on the test.
No, it wasn't like, yeah. I think we should just start
All right, come on.
because all these questions.
She didn't tell you what's gonna be on the test, but what now?
She didn't tell us what was going to be on the test. She just gave us guidance to what we needed in order to be successful in her class. What she said, for example, she said, follow the syllabus, don't dig too deep. She didn't go rambling on stuff that wasn't pertaining to the syllabus or what we needed to know. For
So
the
you
test.
said Ms. Hosey is rambling on things that's not.
Oh, okay, all I was asking for was like, like a pay attention. Pay attention. Yeah.
disease process. It's on every fucking test.
Everybody's different learners than you are. I'm not trying to be like, give me the fucking answers. I'm just saying,
But
the
that's on every
guidance goes
test.
a long way.
ABC, there's a disease
Yeah,
process.
that's every exam, but I still didn't do well on this last one.
Right.
So I'm telling her what I need.
Okay, but she's not.
For $3,000 a semester, I should be able to say, hey, help me.
But it's nursing school, like it's gonna be hard.
It is gonna be hard. You're right. I don't want to repeat.
Well, neither do we.
I don't feel the same. Right?
I feel you, girl.
I'll be back in about 2 minutes. We'll discuss other things when we have a little more time. Everybody saw the change in schedule for Thursday? And thank that to one of your classmates who. Thank you. Yeah, suggested that for you all. So hopefully that should help some. Hopefully. Yeah.
No, but I did do that.
So what are we gonna be talking about? Everybody should have read something on pediatric emergencies.
Shaken baby syndrome, things like that. And we got a report.
Report and what else?
Document.
Report and document. I say document and report. That's very, very important. The documentation, because you can tell all day, but.
It's not documented, it wasn't done.
Right. And that's the time when you do some very, very detailed documentation. Right? You need to be specific, describing things like they have occurred. That means that y'all pretty much read a lot already, so we should be able to not spend a lot of time here. Sounds good. You want to get out early tonight?
No, I need some lecture.
Yeah, I've got one, but.
There are other sections.
Exactly.
So what are some factors predisposing to physical abuse?
Parental characteristics.
Broken bones, fractures.
Divorce, poverty, unemployment.
Poverty, unemployment, social isolation, young parents, just due to the stress, single parents, all that. Characteristics of the child, that they possibly may abuse, maybe under the age of 3, right?
Yep.
Disabled and preterm, so we can understand why we chose those, right? They're very vulnerable. Probably won't say anything. I'm sure a lot of you all have heard the talk on the young lady who had been abused, right? Yeah. It's really something. A lot. So it happens. It happens every day. That's what our CAST presentation webinar will be on.
Oh, okay.
Abuse, but kind of like, and it's not nothing to step on any toes with religion or anything like that, but it's kind of showing it in faith-based environments, you know, how a lot of things happen and we don't expect it to, based on that. So what are some signs and symptoms? We need to be able to distinguish and identify the types of, it could be physical neglect, emotional abuse. But as a nurse, upon admitting a patient to the pediatric floor or even in the ER, immediately I can observe and I can note things immediately without saying a word. So that is our job. We're the advocate for the children, and that's what we do. I document. I don't need to leave the room immediately. I talk, I communicate, and I observe and I assess my client. And so based on all of those factors, that can warrant the physician doing a social service consult, and then social services possibly notifying what Department of Human Resources, and on and on and on. Just based on findings, assessment, obtaining lab values, urine specimens, things like that, seeing a vaginal discharge, from a 3-month-old, seeing genital warts on maybe a 6-month-old, things like that. We know that should not be, and that warrants further investigation. Different type of fractures that can occur on children. Physicians can allude that to abuse immediately, just based on that. Bruises, even children going to school, the teachers should be looking, right, observing how they appear. Are they groomed? Have they eaten? Are they saying that they're hungry? They're starving? They haven't had any food for a couple of days, and things like that. So we definitely got to identify and report. It is our duty at all times, really, no matter where we are. People just think that, just even in the grocery, even at the mall, wherever you are, you should want that child to be safe. And it is your business. A lot of people say it's not.
So if a child comes in and we suspect abuse, do we keep the child there until...
Where are you and what are you doing?
I guess just the hospital.
The hospital. You're the nurse?
Yes.
The parent, somebody had to bring them, right? Admit them.
Yeah.
Right. So what are you saying? You come in the room?
So do we keep them there until the law how does that work?
Okay, 9 times out of 10, my cases have been the child has been admitted, even by the parent. The 2-year-old that mom said that she said he stepped in he's burned, from the feet up until maybe mid, the leg area, but she just said he stepped into, hot water. Really? Yeah. So that story doesn't add up, right? 2-year-old?
Yeah.
So she already knows immediately, that child will be, that child is being admitted because she knows something. She know what happened, but she's making it seem like maybe the child just been vomiting and, things like that. She give other signs and symptoms, So she's saying, I think he's just dehydrated, He possibly is, but that's not the main reason why she's admitted.
So do we send the child back with that person?
That's not our job at all.
Okay.
That's the physician's.
Okay.
And the physician takes over, and he formulates orders, and so it's a whole team comes in, and then, but it's out of our, because we're doing what we're supposed to when we're assessing and we're documenting and we're notifying the pediatrician, because sometimes the doctor don't come in right then, you do, you know, as the nurse. I'm coming in, I'm assessing, taking vital signs, all of this and that, asking all the admission, you know, questions, and then we proceed.
Okay.
Good question. So physical abuse, what is that? Deliberate infliction of physical injury on the child. Can be shaken baby syndrome. Violently shaking the infant or young child. Brain is still developing, and so that's pretty much why they, you know, immediately die, right, from the parent. A lot of, I've encountered situations where some of the single mother's boyfriends, not the father of the child, but they,
Or even the babysitter.
been sometimes, the babysitter too. Number of reasons, and some said the baby just wouldn't stop crying. You know, maybe 3-month-old really, and I think one. I don't know if it's going to be in this webinar, maybe so, but the individual, the gentleman, had the baby and shook him so hard, and then he kind of like took the baby and just slung the head into the wall, and the wall has an indentation, but he painted it, you know, so it had an indentation with blood on it and all of that, but he painted it and all that. So when they came to start investigating, somebody just looked, and they just said they just kept looking over at that wall, and then they started, yeah. And so, you know, terrible, you know, kill the child, you know. Prognosis of shaken baby is very, very poor, right?
Mm-hmm.
Very, very poor with shaken baby, but it happens a lot. Sometimes we cannot, you know, just say who is actually the, you know, person who did this. Sometimes we cannot, you know, you hear so many different stories and this and that, and so it takes some really detailed investigation and things like that. And most of the time, for some reason, the mother, you know, agrees with the person who possibly did cause the injury, and so that's pretty sad. Munchausen syndrome by proxy. Had a case there, maybe 5 or 6 years old, I think. Just kept coming in from gastroenteritis, vomiting, things like that. Just, you know, did all kind of lab work, tests and things like that. Never could find out anything, you know? What's going on? Beautiful child, beautiful family, you know? He kept having so many repeated admissions that we just got attached to the entire family, you know? Knew everybody by name, you know, siblings, things like that, parents. And for some reason, I don't know when he got transferred to the intensive care unit. I'm not sure what their reasoning was, or did one of the pediatric intensivists kind of like, he kind of, thought something was going on, you know, and the nurses, we just like, really? No. But, so they had cameras up in the room. Mom didn't know about it, and she was actually giving him the Ipecac syrup, you know, and to make him vomit, you know, and so she was causing the problem all along. And physicians said that they see that a lot with, you know, sometimes couples and that one parent doing something, inflicting harm to get attention from the other spouse. And so I think at that time they were having some, you know, troubled times in their marriage and possible divorce and things like that, and just what she alluded to. And so, yes, she did lose total custody, you know.
What was she giving him?
Ipecac.
Syrup, the kind of syrup that will
Induce projectile vomit.
Maybe sometimes they used to give it sometimes for some different type of poisons and things like that. But she was giving that to him on, you know, like several times a day. And you know, a child is just kind of like, Mom, this is my medicine. I don't know, you know. And so 5 years old, he didn't question, right? And so you can't look at the family, you can't look at the structure, you can't look at any of that, because, you know, nothing was there to say anything else, you know. Not poverty, not unemployment, you know, married couple, been married for years, you know, so just,
I just said there's a movie about that, where a girl thought she was like allergic to the sun, so her mom kept her in the house, and it turns out there was nothing wrong with her. There's a lot of them.
You'll see a lot of things like that in that webinar. Yes?
So, like, do they do, like, a lot of doctor shopping to find out, like...
Do a lot of what?
Doctor shopping.
What do you mean, doctor?
Like going to different doctors.
Not generally. I mean, this patient came to our hospital each time, every time that child was ill or seemed to be ill, she came there.
So it's just attention seeking.
She was attention seeking from her spouse, So she knew that would, you know, make the husband, right,
come home,
be there with her and things like that if his child is ill, you know. So that was one of the reasons, That was one of the reasons,
Is it Munchausen syndrome like a mental disorder where a person just keeps acting sick?
A mental disorder?
They just say something's wrong,
Yeah, something's always-
and they'll make themselves sick sometimes. But this
I'm
is
not sure. This is Munchausen by proxy.
Oh,
And so
okay.
proxy is the, yeah, no. But that could be, within
It's
a
a
mental
mental disorder.
Yeah.
With the children.
But it's got to be a mental, it has to be, something totally mentally, impaired there she is, because it doesn't really matter. If you and your spouse are not getting along, who's going to cause harm to anyone, but most often, most definitely the child to get attention. So yeah, it is that. So sexual abuse. Sexual abuse, we see that with whom mostly? Who's usually the perpetrator?
A male in the
Somebody in the
family.
family.
The boyfriend.
Someone that they know, somebody within the home, maybe. Could be the
Or
father.
their parents' best
Could be the
friends.
uncle. Yeah. Could be a good friend of the family, And, it used to be a time when you just really had to teach
Yep.
the females, but you have to teach
That's
both
my
sexes
daddy's best
now
friend.
because it's being done to the little boys as well, right? Parents just really, really got to be, careful is the word, but you got to teach your children once they're at the age to understand. You got to be very, very, you are the advocate for them and to protect them. And I'm not saying because it happens to someone's child that they've been negligent, but, you just need to be protective of your child. Your children should be with you at all times. And sometimes you don't know, but you just need to tell them, whether it's dad, whether it's mom, whether it's uncle, whomever, please let me know. And like she stated in the girl who gave the story, that, they tell you what they're going to do. They're going to kill mom and dad. They're going to do this to it. So, that frightens, that's going to frighten a child, make them not do it. But you tell them, no matter what someone tells you, you come and tell me. So you have to kind of revert that and change that up a little bit. And you got to just be very, very cautious because it can happen very, very quickly. And then, for several years,
That's a long time.
So just be mindful of that. So that's the definition of it. I'm not going to read it there, but the typical abuse is male whom the victim knows. Just won't say about that incident, but sometimes it's within an apartment complex that you live. Have to be mindful of those who are, always want to greet the kid with candies and treats and things like that. You have to just be mindful of that. It can be at church, it can be at school, it can be anywhere. So you gotta let the children know. The environment doesn't, it does not exempt.
So
It
what
can be with
age,
the pediatrician. It can be with the physician sometimes.
what age would you say that the nurses or we start teaching the parents to tell the kids about that?
We're not teaching the parents that. I'm just saying that's what parents should know. That's something that they should just automatically know. If a case that comes, then maybe we may begin some teaching then. But just as a parent, that's just parental understanding. As before you even become a parent, you should already know that you are the protector of your child and the environment at all times, and that anyone can be a suspect. And it can be a close relative. It can be the grandfather. We hate to say it, but it can. Sometimes I don't know about males holding little girls, all the time in their lap, and then you just have to be careful with that because you really don't know what's going on, And so, and I'm not saying for you all to go home and start, Ms. Hosey say to that, but you have to, believe it or not, it's just so prevalent. It's terrible, and it affects you for the rest of your life. And so that's in that webinar as well, that any childhood event that occurs in a child's life, it affects them for the rest of their life, and it can deduct number of years of life from you because it causes you to do other things, alcohol, drugs, and things like that. One young lady that's in the webinar, at 15, she's very promiscuous. Parents didn't really kind of understand it, but the parents, I'm not gonna say they didn't understand it. Other people did not, but the parents had some idea. But I don't know if it was her father or uncle, whatever. She'd been sexually, had been having sex with her ever since she was a little girl. So that's all that she knew, and that's
that was
the
normal,
behavior that she, that's what she did. And so some people were looking like, wow, this young lady, why is she, So every time, most of the time, when people act a certain way, there is a genesis to it. And so you need to not, try not to condemn and say and this and that until you really get the true facts. And then you'll be like, wow, I hate I said that, So we have to be mindful of that. So it can affect any socioeconomic background. It doesn't matter whether you're rich, poor, or whatever. You are not exempted from child abuse. So what do? Report, right? I should have the number to call. A lot of times some people may say, I just don't want to give money, and that's fine. They're not concerned about your name and all that, but they want the information on whom you're talking about and details and things like that so we can do things. A lot of people say just in public with seeing parents discipline their children and things like that, that's their child. But we know proper discipline, and then we know when someone is really causing physical harm or whatever, or even verbal, just the way someone talks to someone. Verbiage can affect you for the rest of your life, because you have low self-esteem and other things can occur, So we know what's not right and what is, So nursing care of the maltreated child, you want to identify abusive situations as early as possible, immediate. That's your duty. You just got to do that, History pertaining to the incident. Main goals to protect them from further abuse. Many children have been taken away from their parents, yes. Sometimes the grandparents are there. Sometimes the aunt, uncle may, take them and adopt them and things like that, It just depends. So injury prevention. How do we prevent injury? We kind of talked about some of these things already. So this is kind of overlapping a little bit from basic concepts. But aspiration of foreign objects, what are we going to do there?
Watch your kids.
What else?
Safeguard everything.
Safety is the main thing. So crib safety, right? The home, keeping safe. What else did you all say? Give them one.
Car seats.
We do the finger sweep, but a lot of with the BLS and things like that, they're saying on PALS that we if you can see the object, then you can. But now we're not really doing the finger sweep like we used to, just to assess for that. If the object is visible, then you will. Yeah. Suffocation. So what do we do there? How we want to prevent suffocation from occurring?
Things around that they can choke.
Right. No plastic off the mattress to the crib and other objects, things like that. Motor vehicle injuries.
Car seats, proper fitting car seats.
Proper facing.
Okay, rear facing. Everybody understand that? Rear facing.
One seatbelt per child.
You might say that again. What with the helmet? What has wearing the helmet? What has that done?
Protecting them from having brain injuries.
What is the percentage about?
Ooh, I don't
Pretty
know
good. About 88, 86, somewhere in the book says like that. Just due to wearing the helmet has really made a great improvement. So we really need to enforce that. If you can't get another brain, have injury, then you really can a bleed, edema, things like that can cause fractures, skull fractures, increase in intracranial pressure, and then, the child is kind of like getting major problems there. Falls. What do we see? What age group has the most falls?
Toddlers.
Why?
Because they're learning to walk.
What else?
And they're curious.
We said something from the last.
They climb.
What is that called? Cephalocaudal. The head is larger than the trunk. The weight is in the head, pulls the rest of the body. Unsteady gait, growth in motor, causes them to fall. What about poisoning?
Getting into stuff not childproof.
Call the poison control.
Call poison control. How do we keep the home safe?
Lock cabinets. No lead paint.
Carbon monoxide monitor. No caustic cleaning agents in the lower cabinets, right? Medications should be properly put up, and really, even your school age preschoolers, you don't really want them to just know where your medicine is. I think there should be somewhere that they can't even get to it and things like that. Because you'll see one slide where they show the little boy taking the pills. I think they're colorful, look like candy, and so he's just eating them one by one.
Keep your
You know.
tripods up high.
So,
They said, it says don't take medicine in front of your kids.
right. Because they watch everything that we do, even if they can't really say or whatever, but they're watching all the time, and they mimic us, right? They mimic us a whole lot. How can we prevent burns from occurring?
Check your bath water.
Very good.
Intern the handle.
And then we should be present, right? With the toddler, the infant, the preschooler, even the 5-year-old, you know, you should be assisting them probably. When they get about 5, they kind of like, no, I can do this, but, you know, you still need to assist them. You still need to assist them, you know, for a while. And, they should be able to use, devices in the kitchen, until they are really responsible age, probably a teenager maybe, really. Cooking and things like that, and turning on the stove, and I'm not even sure with the microwave, but I'm sure some kids do, That's why a lot of kids are fed Hot Pockets all the time, and they're not very nutritious, but they know how to pop it in. But sometimes, mom is a single parent or whatever the case may be, and she's tired, and she shows them how to do that. She shows them how to put the little dinner in and things like that. So we do some things, because we have to, right? But we shouldn't probably identify that to our children, because we want to make sure that they're monitored. And then I'm kind of concerned about the radiation from the microwave a whole lot. I like toaster ovens more, so then makes the food taste better. And then the radiation, I'm just concerned about it. I don't know, no research, no data on use of a microwave, but I'm sure, in the long run, it's probably not great for us to use all the time, but we do. What about drowning? What's another word for drowning out of your book?
Near drowning?
It's like
Submersion injury. Submersion injury is being used in place of near drowning. And so, what age do we see, and what are the reasons? Like the infant, we see them drowning where? Bathtub. And then toddler may fall into a pail of water. School age, preschooler, school age may what? In the pool, and then our adolescents, they say mostly lakes and things like that, big rivers where they've gone swimming and things like that. But time is of essence for everything with the drowning. So what does the drowning cause? What happens?
Hypoxia.
Hypoxia. So lack of oxygen, they're aspirating, and it gives different factors.
What did you say the main one for school age was? Pools?
Pools, pretty much, swimming pools. I think those are other examples as well, too.
I could break it into.
Yeah. It says that when there's immersion of the liquid, it results in their drowning or survival at least 24 hours after submersion near drowning. And I said for less than 1-year-old, the bathtub, top-heavy toddler, pail of liquid, preschoolers, swimming pools, school-age children, and adolescents are more commonly in the natural bodies of waters, lakes, pools, and rivers. So they have pulmonary problems and cardiovascular problems, and then it affects their neurological status as well. So they got cerebral hypoxia, morbidity and mortality pretty much in minutes due to lack of oxygen. Then they have a loss of consciousness, right? Decrease in their cardiac output, which leads to apnea and then cardiac arrest. Recovery is timeliness and effectiveness, initial resuscitation, and subsequent supportive care measures. Someone mentioned about aspiration, hypoxia, and hypothermia.
What did you say about 24 hours afterwards?
survival, at least 24 hours after submersion near drowning, they may have a better chance if you
Can get them to last that
as quick
long.
as possible. Yeah. And then it says
Is that like when, like let's say where a kid goes swimming and they're fine and they get out of the pool and then later on they drown? Is that it?
say that again now.
Because they have like different types of drowning. Are you talking about the drowning where like the kid goes swimming and the parents get the kid home and then later on?
But I mean, how did they, when they get him home, what has happened? I mean, what
What
happened at the pool though?
They aspirated water, but not enough to drown right then. They call it dry drowning.
So did they actually take them to the emergency room up
They
there?
didn't know that they were drowning.
Mm-mm.
They didn't
took
know
them-
that they had even.
Aspirated anything.
Oh, okay, yeah, okay.
But that's not what you're talking about with 24
No,
hours.
that's-
You're talking
that's not what
about,
I'm talking about right
Right.
now. This is just actually being submerged underwater based on age. I mean, we can say from the bathtub, any of this that I've just said. And so what it says is that the cerebral cells sustain irreversible damage after 4 to 6 hours of submersion. And so that's the main problem there. And that's why we say really, time is of essence, but a lot of people say we just don't know how long they were there underwater. And when you get a case like that, you don't want to tell the parents, I haven't seen really, out of the years of where I haven't seen anyone really, if they have survived, they're just a vegetable, they're just really a vegetable. They're not talking, nothing like that. I mean, they're breathing probably on their own and things like that, but they're just really, the heart and the lung, they said 30 minutes, within 30 minutes, no amount of liquid aspirated will possibly cause arterial hypoxemia, atelectasis, and things like that. So time is of essence, and less than 5 minutes. And if they say that the child maybe it was less than 5 minutes, they were underwater, and their vital signs are stable and things like that, pupils are reactive and things like that, they really have a greater prognosis, less than 5 minutes. So we see the time frame, those hours is really causing that cerebral irreversible damage to the brain, and so that's really why they don't survive. So those are just some things, just some highlights, that you will see something on drowning and how you will handle that.
Does it make a difference with age too? Like if it's someone who's younger and they more prone
Probably.
to mortality?
Probably. I would think, because like a 2-year-old, I think the shorter in stature, the smaller body weight and things like that, probably will just really cause more problem there, and aspirate water just so much quicker, and then they don't really know probably how to swim, as opposed to another person. And that was a good question. As an older child who probably does have some technique in swimming and really is going to try to whatever. Because sometimes you see that happening even in pools, and somebody see the child, and then somebody, but they're still, fighting. They go under, they come back up, and somebody still, the lifeguard or someone out there still kind of, saves them a whole lot.
I was just curious. My friend's 2-year-old drowned 4th of July. So.
Not good prognosis with it. At home.
Yeah, I was at their parents, on their pond, and so they found him.
And that's what it is. Even like at gatherings, seem like sometimes we're all in the house,
That's what happened.
and everybody's entertaining and things like that, and and so the gate is left open, and that's what they do. They're curious and they walk and they look and they things like that. And it's so sad because that's the story that we hear most of the time. Then sometimes the mom say, "Well, I thought the older sibling had their thing." But they're so short and they just get through. That's why you have to really watch them, because they move so quickly. Like shopping, you really can't. They got to be in the stroller. The stroller. What is it?
The buggy.
Yes. The buggy or something. But then some crawl out of that. One incident, the infant the toddler was in the stroller. She climbed out of the stroller. Mom was probably looking at something. They couldn't find their baby, little beautiful, in a store, but they found her. The parents were just, the father, everybody was just, because you just never know. The main thing that I'm thinking, what? Abduction, right?
Yeah.
Somebody has my baby. Because sometimes people are, that's where abductors go to different places like that, get hospitals, places to get kids, right? They want a baby, they want to, All right.
What would you do if, I know this is the second last summer where a child drowned, well, he was a great swimmer, but he slipped into somebody's pool area that he always did normally. He was swimming, he was fine, but because they had cleaner solution in the pool,
Oh my goodness.
the chemicals is what actually killed him. So in that case, would you, if you found him, you don't know how many hours, would you take him out and call for control? Or you would probably know what do you do in that case?
Depending on what facts we had, we probably still would try to resuscitate him. You know what I'm saying? We probably would try to do the best that we could, unless somebody gave us that information, or we could really tell, when we went into that something is, not right. Yeah. Yeah. Oh, that was terrible. So it wasn't the near drowning. They think he would have survived. So there was somebody was cleaning the pool, the Clorox and all, bleach and all. Yeah.
So after so the first thing you would want to do, I read somewhere, is it CPR, the first thing you want to do?
Yeah,
To do the oxygen.
Right. Oh yeah, you gotta do the CPR or the CBA, right?
I had the order.
Circulation, breathing, and airway is the kind of like, but depending on this situation, it probably would be airway, but we have changed it to CBA. So everybody make sure, right? So what do you do first?
Compression.
Right. So CBA is what you would do, and then you would proceed. I don't know what kind of situation would help you if you're alone. That's the saddest thing about it. Even if you're a parent at home, what are you gonna do? Somebody needs to be calling 911, but you also need to be right. But most definitely you got to do CPR, because due to lack of oxygen. But we're trying to get them to the hospital setting. So when we get to the hospital setting, the main thing is hypoxemia and things like that. It's probably going to be ventilatory support and all. They're not going to be breathing on their own, probably not, right? So they'll probably be on a ventilator for a while, CBA is circulation, breathing, and
Airway.
So bodily damage, and we'll stop there. Everybody, what kind of bodily damage can happen? We see that in our older kids, right, school age, adolescents, they're climbing trees, things like that, scrape their skin, they fall. And the children that, out skating, that on protective gear, should have the elbow pads, knee pads, and your helmet on, all of that at all times. Just want you guys to look at that slide. That pretty much tells it all there. And the child here, this happens, right?
Yes, it
Sometimes
does.
we have the child in the lab with us. We love them so much, right?
Or you put them in their car seat and they magically get out of it. And they magically get out of it and pull the car in gear.
They do that too. My niece actually, I don't know what happened. I was married at that time, but we were at the bank. And I was meeting my husband there. My mother was with us. But I think my mother was driving. I don't know. She was about 3 or 4, and she pulled the cars.
Just rolled off. Yep. Mm-hmm.
So we out here trying to, I'm
been there and done that.
Test the car, really.
Well, I learned that habit at 16.
Spank that child, but we gave her some love and say, really? Yeah.
Yeah, I learned that lesson at 16.
She was about, yeah. Okay. All right, we'll take a break. Yeah.
Yeah.
Oh, y'all know y'all need them breaks. What's up with all that?